I'm Dr. Liz Schumacher. I'm a pediatric psychologist with the Norton Neonatology Follow-up program and also an associate professor at U of L. And I am pleased to be able to introduce Dr. Hannah Fisher. Dr. Fisher is a neonatologist with Norton Children's Neonatology, and she's also the medical director of the Neonatal Follow-up program. She completed her medical degree from the University of Louisville and completed her pediatric residency at Cincinnati Children's Hospital and a neonatal fellowship here back at U of L. And then she ended up joining the Division of Neonatology as an attending physician. She is also the Director of Quality Improvement and Safety for the Division of Neonatology and is actively involved in improving outcomes for infants cared for by the Norton Children's Medical Group Neonatology program. And with that, I'll let Hannah take over.
Thank you, Dr. Schumacher. All right. Thank you for inviting me to come to speak to you guys today. It's always exciting to get to share what we do and hopefully partner with you as we take care of these babies that have complex neurodevelopmental needs that we'll talk about today. I have nothing to disclose for this presentation. So my goals today are to introduce you to our neonatal follow-up clinic and the people that are part of it, and then talk about what we do and some of the data that we have, and then things that you can do in your practice to help support us and these families. And so we meet patients and their families that have congenital heart disease even before they're born prenatally. We're part of the team that consults with these families and helps them understand what their trajectory is going to look like, and then take care of them during the delivery and their time that they spend in the NICU, and then come in again at the time that they transition home. And the transition to home for these families can be very daunting. They have a complex child with lots of medical and developmental needs. And so we can help explain the role of our clinic and what they can expect, and hopefully help them transition home and in a safe way where they can be empowered to care for their children. These families follow with us in our neonatal follow-up clinic, typically for the first 18 to 24 months of life, but sometimes even longer. And during those visits, we help manage any medical issues, help them optimize growth, and prevent and recognize developmental delay and intervene early, getting them into early intervention services and support the family. And then we continue to do this and ongoing and help them transition to preschool-based services and other support that they may need as they grow into toddlers. And so the goals of our neonatal follow-up clinic are listed here. Clinically, our goal is to provide medical and developmental support for families after they're discharged home from the NICU, and we do this throughout the state, and particularly address unique challenges of these high-risk populations in a multidisciplinary manner. We also collect and use data to improve outcomes, both from a research and quality improvement standpoint, and then work to train and support the next generation of neonatal care providers. Introduce you to our team and explain a little bit more what we do. So our medical team consists of nurse practitioners and neonatologists, that work in Louisville at our Novak Center, as well as our Norton Women and Children's Center. We also see patients throughout the state and in Owensboro, Paducah, and Bowling Green. Our developmental team consists of 2 occupational therapists who help us to assess our infants and provide home programs and things for families to work on, as well as helping them to get in early intervention services. And then a cornerstone to that is Dr. Schumacher, who you met today, is our developmental psychologist who performs standardized testing and helps families with recommendations for early intervention services and preschool-based services. We're also supported by our social worker, Lori Hibbs, our clinical nurse specialist, Angie Guest, our medical assistants and clinic managers. And we partner with Laura Dean, a dietitian with the cardiology and pulmonology groups to help care for these babies in the best way possible. As I stated, we see patients throughout the state of Kentucky, mostly in the western half. We're supported by a grant from the Cabinet for Health and Family Services that allows us to come out into the state to see these patients and provide the best possible care, just like the patients that live in the Louisville and surrounding area would receive. And so these sites are Owensboro, Paducah, and Bowling Green, and we see patients there every 3 months. We also partner with First Steps, which is Kentucky's early intervention system. Through our clinic, we are able to perform First Steps evaluations for our patients directly and get them into the services that they need. So we're going to transition now to talk about neurodevelopmental care for the child with congenital heart disease and give you a little bit of insight into what we specifically do during our visits. So this is a statement supported by the American Heart Association and the AAA regarding neurodevelopmental care of infants with congenital heart disease. In this statement, authors outline the risks of developmental delay in this population and what screening and intervention should be performed. And so, as you all probably know, there's an increased risk for developmental delay in multiple areas in these children. So specifically in the areas of intelligence, academic achievement, language, which includes expressive and receptive language, attention, executive functioning, fine and gross motor skills, and also psychosocial skills. And this risk of developmental delay increases with the complexity of congenital heart disease. The screening protocol put forth in this paper proposes a risk-based algorithm for evaluation and diagnosis based on the complexity of congenital heart disease. And highlights time periods where screening tools should be administered versus standardized testing, but also provides a pathway for getting children into early intervention services sooner and improve developmental outcomes.
For some of
They're still going to have that in there.
Oh, it's all day. It's all day.
All right. And so this is specifically what our clinic provides and kind of operationalizes from this paper for our babies with congenital heart disease that have a surgery within their initial stay. So after discharge, our first goal is to get them in within 2 to 3 weeks of discharge with a medical provider, especially to assess their growth and development, their transition home, make sure things are going well. At 4 and 8 months, they continue to be seen by a neonatal medical provider, but they're also evaluated usually by our occupational therapist to assess their development and perform a first steps evaluation if that is necessary and get them into early intervention services. At 12 and 18 to 24 months, they see a neonatal provider as well as our developmental psychologist for standardized developmental testing. And that during that time, give them evaluation of strengths or weaknesses and recommendations for services. Babies are seen more frequently by the medical providers if there are growth or medical issues, especially if they have a G-tube, are not feeding well, or not growing well. And we partner with our dietitian and social worker during these visits. Some of the developmental screening testing that we do. So every single visit that they're seen, a medical provider does a Denver developmental evaluation. And this is a screening tool that tells you if their development is delayed or suspicious. And if we are concerned, then we do more specific testing to fully evaluate their development and if early intervention services are needed. The occupational therapist and developmental psychologist at that 4 to 8 month time period will use the Bailey Infant Neurodevelopmental Screener, or the BINS, as another more specific screening tool. And then the Bailey Scales of Infant Development, now 4, is the standardized test that we use at that 12 to 18 and 18 to 24 month. It looks at all the realms of development and compares the infant skills to the general population, essentially, and lets parents and providers know of strengths, weaknesses, and we can use that to help guide intervention services. And as I stated before, we also are able to perform directly first steps evaluations for our patient population and get them into those services. I'm going to talk a little bit about hearing screen recommendations because this is really important in this population and is to improving language and communication outcomes. So the early hearing and detection guidelines state that infants should undergo hearing screening at the time of discharge or by the first month of life. Within infants that are having concerns on screening, have an audiologic evaluation no later than 3 months, and ideally starting early intervention services if needed no later than 6 months to improve hearing and communication outcomes. So infants with congenital heart disease are at higher risk for hearing loss for a number of different reasons. And so the recommendations are that if a child has been on ECMO, which many of these children they have been, that you repeat hearing screen by 3 months. Other reasons to repeat hearing screening by 9 months are exposure to ototoxic drugs like Lasix and vancomycin and gentamicin that oftentimes these children are exposed to. If they've been mechanically ventilated or are in the NICU, or I would extrapolate that to the pediatric CICU for greater than 5 days. So this is going to encompass most of the babies in this population that we're talking about. So most of these babies should have hearing screens repeated by 3 months or by 9 months. And this is important because many children that pass their initial newborn screen will be identified with deaf or hard of hearing later on. The ABR screens that we typically do in the hospital don't detect hearing thresholds that are at the borderline or mild range of hearing loss. And so these infants may startle to loud noises, and oftentimes the parents will report that they think that their child can hear, but they're going to have difficulty with distinguishing the sounds of language and won't be able to hear things such as a whisper or rustling leaves at that level. And so the goal is to identify this hearing loss early and get them into intervention and improve their hearing and language outcomes. And so there are options, many options for audiologic follow-up in Kentucky. The Early Hearing Detection and Intervention website is a great resource and has lists of audiologic providers that can care for your patients that you can refer them to. I'm going to shift now and talk about a population that we do have some good data on from our clinic. And it seems to me to be a higher risk population. So the infants with congenital heart disease and requiring a G-tube placement prior to discharge. So we are in the process of performing a retrospective study looking at children with congenital heart disease and a G-tube discharged between 2015 and 2019. We have 49 infants that we're evaluating from Norton Children's NICU or CICU, and we're looking at growth, feeding, and developmental outcomes. So here are some of the highlights from the data that we have. Infants with congenital heart disease that are discharged with a G-tube had a high rate of growth failure at discharge, which is not surprising, but unfortunately did not fully catch up at 18 to 24 months at follow-up. And so you can see here that we define growth failure oftentimes as weight less than the 10th percentile. So at discharge, 69% of this population had growth failure. And then at 18 to 24 month follow-up, 62% continued to be less than the 10th percentile for weight. And we know that good growth and nutrition improves neurodevelopmental outcomes. So this is concerning. As far as feeding outcomes, the majority of infants with congenital heart disease discharged with a G-tube in this population that we evaluated continued to require a G-tube for nutritional support at 18 to 24 month follow-up. And so in our cohort, 28% of infants still required full G-tube feeds, and another 45% were still on partial oral, partial G-tube feeds. 26% reached full oral feeds, and of those, they had their G-tube removed at an average of 292 days, so a little bit less than a year. And those infants that remained on full G-tube feeds at follow-up were less likely to have received early intervention services, particularly speech or feeding. So if you look at our data, those that required still were requiring full G-tube feeds, only 45% of them were receiving any therapy, whereas for the infants that had achieved some oral feeding to full feeding, 65 to 70% of them were receiving some sort of therapy. As far as speech therapy was much less in the fully G-tube fed population, just 27%, compared to, again, that 65 to 75% of those that received, that were able to achieve some form of oral feeding. Feeding therapy in Kentucky, especially during the time period that we were looking at, is very problematic. there's not as many therapists that are trained and comfortable with providing feeding therapy in infants in Kentucky as probably the need, and there's a mismatch there. And there's a lot of crossover between speech therapy and occupational therapy with feeding therapy. So it's a little bit hard to delineate how many of them were getting dedicated feeding therapy. But the data is there in this population for you to see. So as far as developmental outcomes, out of these 49 infants, 16 of them had a Bayley Scales of Infant Developmental 3 assessment performed. So very small numbers, but those that did have this performed did demonstrate significant delay compared to the general population. Greater than 60% had scores 1 standard deviation below the mean. And 40% had communication and motor scores greater than 2 standard deviations below the mean, and so problematic. The lowest scores that we saw were the motor scores. This may be related to their underlying congenital heart disease and treatments for that. And you would need to compare to our total congenital heart disease cohort to see if it's different than other babies that didn't have a G-tube, but still had congenital heart disease. But I think overall this shows that babies that have congenital heart disease in a G-tube are at particular risk for developmental delay in all realms, not just with communication and feeding, but motor as well. And so I'd like to take a moment to summarize some of the things that we talked about today and things that you can do in your practice. And so use recommended screening tools to identify developmental delay early in these populations and get them into early intervention services early. If you're not sure what is the best screening tool for this population, there is a policy statement from the AAP that goes over different methods. And you can always partner with us and call the Neonatal Follow-up Clinic if you have questions or concerns about infants with congenital heart disease that you know are following with us, and we can help make recommendations as well. And then you want to refer for repeat hearing screening per the recommendations as well. I want to take a second to talk about our neonatal follow-up discharge to home consults. So this is applicable to the inpatient teams taking care of these patients and families. So our goal is to help families of medically complex children transition to caring for their child at home in a safe and supportive way. So our neonatal follow-up team has started offering a service to consult with these families before going home. So we consult with medically complex children and their families in the NICU or the CICU who are going home with oxygen or tracheostomies, apnea monitors, G-tube or NG feeds, or complex congenital heart disease. So we meet with the family to establish a relationship with the outpatient team and explain our services and our role, give them contact information. So if something happens in that 2 to 3 weeks before we see them, they know who to call. And we're hopeful that by providing this service, we are going to help that transition home, prevent adverse events and readmissions, as well as delays in care, and improve care for these families as they go home to take care of their children. And so that's a little bit of what we do. And we are so happy to partner with you as a pediatrician in caring for these babies. So please ask any questions now or later, and we're happy to answer those. Thank you.
Great talk, Hannah. Does anybody have any particular questions or concerns? I've got a couple of questions for you, Hannah. When we see patients in the follow-up program, oftentimes they have passed their most critical medical need. Their family's just happy to have them home. And sometimes they're reluctant to add any early intervention services, preferring just to let their child catch up on their own. Do you have any tips or guidance on how you help families make these decisions about adding early intervention services?
Yes, I think that I try to highlight that this time that we have in the first year to 2 years and 3 years is really critical for growth and development. And I like to highlight specifically with first steps that they come to your home, so it makes it a little bit easier on you, taking off the burden of multiple appointments. And they partner with you and teach you how to help and work on your child's development. that you're not an expert in it. You know your child, but they know how to promote good development. And so they can teach you things that you can do every single day, and really try to talk up that aspect of it. I think it is hard, and I think most parents want to do what's best for their children, but you also have to take into account what they're able to do time-wise and emotionally as well.
I've got another question for you too. How do you coach families about the importance of tummy time and other positions for motor development after they're discharged? Lots of the babies that we see may have a G-tube, as you alluded to. They may be on supplemental oxygen. They may have some color changes as they get fussy, and all that stuff makes parents in particular really nervous. How do you help them? What do you say to get them to realize and then implement tummy time?
I think one of the things that we do is pull in our occupational therapists to work with the family. They're the experts on tummy time, and we all know how important tummy time is. And when the children are in the hospital and medically complex, that piece gets looked over. And so our occupational therapist can get them on their belly, talk the parents through some of this. We do that as well. I like to tell parents that doing tummy time is like a little baby workout. It's how they get strong neck, back, and core muscles so that they can later roll over and sit and stand and walk. So I think if you tie the tummy time as not just this random thing that we're asking you to do a couple times a day, but tie it to them attaining those next developmental milestones, it helps the family put it into perspective of the why that they're doing it. And then also highlight that, it is difficult. Some babies really resist being in this position. And so doing shorter times more often, once they start to really cry, you can pick them up. You don't have to force them to stay there for 20, 30 minutes. We're talking a couple minutes, multiple times a day, will even get you a benefit. We have really nice handouts that we use in the NICU or in the Neonatal Follow-up clinic. We have one handout that shows the position that babies should be as they get older and how they should progress. And I think seeing if their baby is not doing that, like they're not able to lift their head off the table, but seeing a picture of what a baby should look like helps the parents understand the goal and how their baby might not be getting it quite yet. And then pathways.org is where we have gotten some really great tummy time handouts and often refer parents to that website.
One of the attendees said, I've been very disappointed in Zoom therapy with First Steps. It's just not as good.
Yeah, it's been a challenge over the last 2 years, and really has hampered the goal of First Steps to be in the home and teaching the parents. So I think it's the best that you can do at times. Currently, First Steps is offering services in the homes for the most part. There might be some situations where they're not, if the family's not comfortable or if a therapist isn't available. But for the most part, they're getting back to being in the homes. And so, parents can talk with their First Steps coordinator and work that out if that's not being offered as much as possible. And then sometimes, especially with babies where they have physical therapy type needs, getting your hands on the baby is really important. And so we have supplemented with outpatient private services when we're able to. And so for some families, that is an ability they have, but for families that don't have transportation or ability to pay for those, that does become problematic, I agree.
Are there any particular red flags for development or feeding on screening questionnaires that you think warrant immediate additional evaluation or referral to a neonatal follow-up program or a developmental center versus just continued monitoring?
Yes. So for feeding in particular, any baby that I always ask about coughing, choking, or gagging when they feed, or bottle refusal. Some babies that are, weak and have low tone or are poor feeders, if they're aspirating, they just refuse the bottle. And so at that point, either we would want to see them or get them in for a swallow study, especially if they're not gaining weight well. As far as development, there's not necessarily developmental emergencies necessarily, but, I definitely think that babies that are, especially with the motor milestones early, that aren't attaining those, aren't able to lift their head, aren't able to push up, and not tolerating that tummy time position so they can even work on it, that's when you want to get somebody involved, a physical therapist, to help support the family and get them on the right trajectory. Because most of these children, I find, respond really well to physical therapy interventions and are able to catch up by that 2-year mark is what we're hopeful for.
If a pediatrician's seeing a baby and they're not being followed by a follow-up program, can they refer them directly to us?
Yes, at any time you can call us, you can refer to us, and we will get your patient in as quickly as possible. So any baby with congenital heart disease, especially if they had surgery in the first year of life, would be babies that we'd want to see, but also with, you know, developmental or growth issues.
Any other questions? Great talk.